agents this week. I've divided it into two. The first part of the lecture, which is today, we'll be dealing with most of the antiviral agents that are used to treat herpes simplex and then CMV. Then hopefully, God willing, on Wednesday, we'll talk about the antiretroviral drugs. Mostly when we talk about antiviral agents, the antiretroviral drugs are the most important in this group. So we'll look at them on Wednesday. Then we move on to anti-TB medications. Okay. So antiviral drugs, like I said earlier, are used to treat or prevent viral infections. And these range widely from influenza to HIV. And these are the major classes that I've listed. The nucleoside analog reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, nucleotide analog reverse transcriptase inhibitors, and the protease inhibitors are antiretroviral drugs or medications that are used to treat HIV infection. The rest are used to treat various other infections, and we'll be taking a look at them shortly. So we'll start with the synthetic nucleosides. And the prototype is the medications that are used to treat viral infections in immunocompromised patients. Viral infections are self-limiting. They don't usually require medication, except when they occur in immunocompromised patients, whereby the immune system is not that robust. And so they need help in the form of antiviral agents to tackle these infections. So these infections include herpes simplex virus and then cytomegalovirus, which we commonly find in HIV patients. So drugs in this class include the acyclovir, famciclovir, ganciclovir, valacyclovir, and valganciclovir. I'm sure a lot of us are conversant with acyclovir. The rest are newer generation. So we would usually talk about acyclovir first before we talk about the others. So acyclovir sodium is used to treat herpes simplex virus, and it causes minimal toxicity to the cells. Ganciclovir is a derivative of acyclovir, and it is mostly used to treat HSV and then CMV. Then the other members of the class are famciclovir, which is used to treat herpes zoster, genital herpes, and then recurrent herpes simplex virus infections in HIV-infected patients. The valacyclovir is used for herpes zoster, genital herpes, and herpes labialis, what we normally call cold sores. And valganciclovir is used to treat CMV in a patient with AIDS. So each of these medications are taken, and then they are widely distributed throughout the body. When you take acyclovir, its absorption is slow when given orally. So it's just about 10 to 30% of the medication that is absorbed, and then it's distributed throughout the body and metabolized inside the virally infected cells. And the majority of the drug is excreted in the urine. When it comes to famciclovir, it's less than 20% is bound to plasma protein. What do you want? So this is also metabolized in the liver and excreted in the kidney. It's always important to look for the odd one out. So ganciclovir is not given orally because it's poorly absorbed from the GI. So it's given IV. And most of it is not metabolized. It's also excreted by the kidneys. Valacyclovir is converted to acyclovir. And so once it's converted to acyclovir, its pharmacokinetic properties are similar to those of acyclovir. It is metabolized in the valganciclovir is metabolized in the intestinal wall and the liver. So how do they work? So what they do is that when they are taken in, they get into the viral infected cells, the virus infected cells, and then they are and when they are converted to the active form inhibits DNA polymerase, and that is how come they are able to disrupt viral replication, and then they halt the viral growth. We all know that DNA polymerase has an active role in viral replication. So that's usually what happens. And for acyclovir, the active form is acyclovir phosphate. And then all the others go through the same thing. So ganciclovir is also converted to ganciclovir triphosphate, and so on and so forth. So when they enter the cell, the viral infected cells, they are converted to the active form. And then the active form inhibits DNA polymerase, which holds the viral replication. So basically, that's how they all work as a group. So therapeutically, acyclovir is used to treat herpes 1 and 2, as well as varicella zoster virus. This is a virus that causes chickenpox. Then oral acyclovir is used to treat recurrent herpes simplex infections. The IV is usually reserved for very severe infections, especially maybe herpes simplex and meningitis. Excuse me. Sweetie, me feel lecture, I'm not going to travel. All right. Go ahead, do that. All right. So this includes shingles. And sometimes you can have disseminated infection in immunocompromised patients. All these infections can be treated with acyclovir. Ganciclovir is specific to CMV retinitis. And mostly you find this in HIV patients or patients with encephalitis. Cyclovir is used for the herpes simplex. It's also good for genital herpes. And then valganciclovir is for CMV retinitis. And then valacyclovir has similar profile to acyclovir. Herpes zoster, genital herpes, and herpes labialis. So drug interactions. So basically, when you look at the nucleosides as a group, they interact with medications that reduce kidney excretion. For example, probenecid. And so when you take probenecid with these medications, it increases the risk of toxicity because the probenecid has renal toxicity, and then these medications would worsen that. Then also, if you take them with medications that are used for chemotherapy or medications that damage rapidly dividing cells, there's tissue damage. So these medications, examples of these are the vincristine, the vinblastine, doxorubicin, mostly the anti-cancer medications. Then amphotericin B, cotrimoxazole, which we commonly call Septrin. as well as doxorubicin and pentamidine. Dapsone is used to treat leprosy. So when you take these medications with these nucleosides, what happens is that they inhibit the replication of rapidly dividing cells. So cells that are found in the mucous membranes, in the bone marrow, in the skin, and sperm producing cells, these cells which have a rapid turnover will be inhibited. So it's important to take notes of some of these things. Then when you are taking ganciclovir or valganciclovir with imipenem or cilastatin, there's increased risk of seizures. And this is very important information for the treatment of patients with meningitis/encephalitis. Sometimes when patients come in with meningitis, you are not sure whether it's a viral meningitis or a bacterial meningitis. So sometimes you might treat with both the nucleosides and then the antibiotics. So in your choice of antibiotics, if you go in for imipenem cilastatin, then you have to be careful when you are using ganciclovir or valganciclovir, but acyclovir is quite safe. So acyclovir can cause reversible kidney impairment when you give it as a rapid IV injection, that is given it for less than 10 minutes. Common adverse reactions to acyclovir include headache, nausea, vomiting, and diarrhea, and then hypersensitivity reaction. And ganciclovir commonly gives you granulocytopenia and thrombocytopenia. So granulocytopenia is reduced neutrophils, and then thrombocytopenia is reduced platelets. And then commonly, famciclovir and valacyclovir will give you headache, nausea, and vomiting. And these are common for valganciclovir. Important to take note of the seizures and the retinal detachment. Those are peculiar. You realize that there is also bone marrow suppression. So there's pancytopenia. So platelets are down, hemoglobin is down, and then the neutrophils are also down. So you have a neutropenia, anemia, thrombocytopenia, basically a pancytopenia. And this will predispose to sepsis. Then they can also have hypersensitivity reactions. Okay, so the next group of antiviral agents is the pyrophosphate analogs. And a prototype of this is called Foscarnet. So Foscarnet is an antiviral drug which is used to treat CMV retinitis in patients with AIDS. And it's also used to treat acyclovir-resistant HSV infections. So a patient has herpes simplex infection, maybe herpes labialis or genital herpes or shingles, and you're treating with acyclovir is not improving, you can move on and treat with Foscarnet. Foscarnet is poorly bound to plasma proteins, and it is excreted and changed in the urine. Its mechanism of action is by preventing viral replication by inhibiting the DNA polymerase, a similar mechanism of action to the nucleosides. And so, like I mentioned earlier, it's mostly used to treat CMV retinitis in patients with AIDS. And also combination therapy with ganciclovir for patients who is not responding to either Foscarnet alone or ganciclovir alone. You can give it as a combination therapy with the Foscarnet. So there are lots of drug interactions. It's important to note that they increase the risk of hypocalcemia and toxicity to the kidney. So if you have a medication that ordinarily leads to decreased calcium levels, giving this medication with Foscarnet can lead to this decreased calcium level. Also, when you give it with amiodarone, there's increased risk of QT prolongation on the ECG, and the risk of toxicity to the heart. So cardiotoxicity is also there. Then when you give it with medications that are toxic to the kidney, like amphotericin B and aminoglycosides, that is also a problem. And so with these patients, because of the risk of damage to the kidney, you have to hydrate them aggressively so that they flushes the medication quickly out of the system. There are lots of adverse reactions. It's important to take note of the numbness and the tingling, the seizures, and then the granulocytopenia and leukopenia and anemia, basically giving a picture of the bone marrow suppression. Then they can also have breathing difficulties and coughing, and then involuntary muscle contractions. Okay, so the last thing we'll look at, the last medication we'll look at is Ribavirin. So Ribavirin is used to treat respiratory syncytial virus infections in children. You remember respiratory syncytial virus infection is a common cause of bronchiolitis. And so Ribavirin is used in the management of bronchiolitis. I must say that it's not common in us. In fact, it's not available in our setting. And so, well, it's good to know, but so usually in our setting, you realize that management of bronchiolitis is supported. We don't have Ribavirin to treat the RSV. So in the treatment of RSV, the Ribavirin is administered by aerosol inhalation using a small particle aerosol generator similar to nebulization. So the administration is either by intranasal route. It can also be given orally, and it can also be given by the inhalation. So it has a limited distribution, and the highest concentration is in the respiratory system. If you take it orally, it is rapidly absorbed and distributed in the plasma. It is metabolized by the liver and by the red blood cells. And the excretion is mainly by the kidneys, with some in the stool. The mechanism of action is not well known, but it is known that it inhibits the viral DNA and RNA synthesis. And this is what stops viral replication and helps with the relief of the symptoms. And like I said previously, it's used to treat RSV infection in children, but it can also be used in combination with interferon alpha 2B for the treatment of chronic hepatitis C infection. There are few interactions with other medications. So if you take zidovudin, which is used for the treatment of HIV, in addition to the Ribavirin, it may cause blood toxicity, bone marrow suppression. Then when you take it with digoxin, there can be digoxin toxicity. And it can also produce CNS abnormalities and cardiac arrhythmias. As for the GI distress, that's common in a lot of the medications. So that's not a side effect that is peculiar to Ribavirin. A lot of medications will give you diarrhea, vomiting, nausea, abdominal pain. So the peculiar adverse reactions to take note of are the apnea, cardiac arrest, hypotension, nausea, and then pneumothorax, that is air in the pleural cavity. Please, are there any questions? Any questions? Hello.
Yes, Doc, we are here. Yes, madam.
Is everybody okay?
Yeah, no question.
There are too
I don't
many.
think anybody has any question. Dr. Mara, this one they like fire.
There are too many
You
things.
knock everybody out.
I'm sure you're wondering how to even master all these things.
You are magic. Of course, it is
Valid
the key
point.
thing.
Valid point.
It is frustrating.
We
are thinking about it.
I keep telling you that a lot of this will come from practice. As you prescribe the medication, you check. So make sure that you get a BNF. Nobody's expecting you to keep the side effects of all these medications in your head. But it's important for you to have a BNF and cultivate the habit of checking. By now, you're a student. And when you finish, you do your internship. Nobody is going to fault you if you keep checking. But it is the checking that will help you to remember. So, for example, you see a patient with shingles. You know, at least basically, that somebody with shingles, it's a viral infection. You need an antiviral agent. And you also know that acyclovir is one of the common medications that are used. So you quickly refer to your BNF. You read on acyclovir, and then it sticks. That's how you learn. The next time you see another patient with shingles, you can remember some of the small things, at least the major things, so that you are able to remember. Because a lot of the time when you start work, it's the things that you picked up during your internship that goes with you. It isn't a lot of the things you learned in school. I must be honest with you. But what you actually need to practice is very little. And those are the things that will be emphasized when you're doing your internship, when you're doing your practical rotation. So for now, a lot of you are in the clinics, you are doing your clinicals. What I would advise you is that if we finish with antibiotics, 4 slides on antibiotics, you're supposed to know everything there is to know about antibiotics. So for now, if you go to for now, if you go to the ward, you are doing ward rounds, or you see a patient, you take history, you examine, and then you come to a diagnosis. At least those ones, I'm sure you can do it. You can take history, you can examine the patient, you can make a diagnosis. Now, when you make a diagnosis, try and find out what medication will you use to treat and manage this condition. So let's say you make a diagnosis of UTI, then you ask yourself, what microorganisms am I expecting to cause this UTI? And then you look through the medications, the antibiotics that you've learned, and then try and recollect or go through and decide which one is important for the treatment of the organism that you are thinking of. That's how you learn. So once you decide that, okay, this treatment, I'm thinking is most likely that it will be E. coli or gram-negative organisms. So what are the medications that are mostly used for gram-negative organisms? So let's say ciprofloxacin. So you quickly go and read on Cipro. You check from the DNF or you read it from your notes. And that's how it sticks. The next time you see a patient with pneumonia, and then you see that, oh, they put a patient on penicillin, then you quickly read on penicillin, and then it sticks. Another time you see a patient with tonsillitis, you realize they put on amoxicillin. What is it? Then you read on it. Common side effects. And then small, you be going. So by the time you finish your practicals, the common infections that you find, those are the ones that you need to practice. I hope this makes it simpler at least.
Yeah,
Onel,
madam.
Onel, Uti. Onel,
you said it nicely. You said it nicely.
So when you are doing your practicals, pay attention. Don't just go through like you are going through. No, pay attention to the conditions that. Pay attention.
Now the doctors, when they start talking like this, it's rah. They talk the thing as if like you have to get it once and for all.
It's always like that.
If they
So
ask you one question
don't
you can't
follow
answer,
them.
then you are emptying urine barrels.
I'm telling you, you go empty urine
All
bag.
of us.
You go empty urine bag.
That's a one more, but that's why
No.
it's because we need
That's
shade
why I can't tell.
on. So don't be
The way they yawa
discouraged.
us,
Don't be
The way
discouraged.
they
That
yawa us,
you learn small, Sanet.
Who say, Madam, who say your cannibal call? And yes, I need tea or field news. Madam,
I know.
Madam,
Me, I said me will leave because
now cry history taking, cry near take your mark, cry saying now, yeah, history taking.
so. But can you imagine if you hadn't had any practical exposure at all? Now,
Dr.
Like it to worry us.
That one there is ugly. Like it would have been a different story altogether.
Because I know now I say what bomba like
over disinfected tray, you will disinfected tray and pan.
Yes.
Good evening.
Good evening.
Doctor, phone number.
Please, the patient is on an amoxicillin and she's complaining of itching. Are you going to stop it or you give antihistamine to continue with the medication?
So it depends on how bad the itching is. So in this case, it's a side effect. If it is not so bad and you realize that it is the best medication for the condition, you can give an antihistamine. And then you see how the patient reacts to it. Are you okay, Mabel? Any other questions? Ask practical questions.
Practical question. Only practical question. Only practical question.
Maybe you start to be put my baby practical question. Oh, madam, baby, I'm wanting to me.
I thought you were all doing practical.
No, where I am.
He's in some village.
Hey.
Baby, I am.
Into the bed now, baby.
Me Jimmy leave.
Leave no
me Jimmy leave and I'm there. Okay.
Hello, Doc. Please, one last question.
One last
question.
Yeah, Mabel, go ahead.
Doc, please, I've realized that 37 Aspen and then gentamicin is mostly used for the children. I want to know why. Is it because it's cheap or that is the protocol?
Okay, so we have a protocol. Unfortunately, the protocol has run out. I'm in charge of the protocol. We printed 100 copies and we sold all. So you don't have the protocol, but hopefully by the end of this week, I'll be coming up with a second edition and then we'll have it printed. And it's our protocol. So our first line, because we don't want antibiotic resistance, Expengenta is our first line. And if you look at Expengenta, it's very broad. The penicillin part covers gram-positives. And then the gentamicin, if you remember from our antibiotic, the notes that we've gone through, gentamicin is good for gram-negative organisms. And so it's a very broad spectrum antibiotic for a lot of infections. In fact, a lot. Once you are thinking of sepsis, that's the first line. And the other reason is also that it's very cheap. And they are very basic antibiotic, very cheap. I think Expen, I think less than 10 cedis. So, you know our people, a lot of the patients are constrained financially. So it's one of the reasons. So hopefully next week, we will have the protocol ready. Then you can buy from the pediatric emergency.
Okay, thank you very much.
You're welcome. Yes.
But some of us will come for personal practical lessons
At home.
now.
At home, actually.
No problem.
Yeah.
No problem. You are welcome.
Okay, that's
Yeah,
why you book a
welcome.
baby.
It's just that November is my leave month. That's why. And yes, Anka, you'd have met me
Okay.
in the hospital. Yeah.
Okay, baby, that's why you book a
Until
baby.
December, Papa Niaba.
When I did you book your coffee.
Yeah, you want a practical.
But you realize that as you go through the practicals, you realize, hey, and I still had
Madam, on DK, I vomited. Trust me. I was scared. I freaked out.
with DK.
Exactly.
Okay. We'll be doing all the...
What's the name?
Yeah. When you read it in the book, it's different from what you see. Yeah. And you see, is that the practical and the internship is the time to make those mistakes. Because when you finish and you are sitting somewhere on your own and the patient comes, you can't run away. But at least right now that you are doing practicals, you will be standing behind whoever is the main person and observing what they are doing. Nobody will put you at the front line, say, go and answer the question. But once you, so this is the time to learn all you can.
Madam, I have a question.
Yes. Yeah.
Talking about DKA, rushed in, and when they gave 10 in 10, the sugar started dropping, but after 30 minutes, the sugar 10 in 10.
What is 10 in 10?
What is 10 in 10?
As in insulin, they gave insulin. Insulin, insulin. Yes, 10 in 10.
10 in 10.
Okay.
Yes. So when they gave the 10 in 10, after 30 minutes, the sugar dropped down, but after 15 minutes, close to another 30 minutes, it went up again. Why was it so?
So we'll look at insulin.
Because I thought
insulin is short acting.
Yes.
Insulin is short acting. So usually when the action of insulin wears off, what insulin does is to bring the blood sugar down. So when it wears off, it will go up again. So there's a whole protocol for management of DKA. We'll look at it. It's all part of pharmacology.
Okay. Thank you, madam.
Don't worry. At the time you finish with pharmacology, you'll be good at writing prescriptions.
Yes, madam.
No, 10 in 10, it's removed.
10 in 10, no. The doctor, why are you putting me in the tight corner? Whilst madam is around.
Okay, 10 in 10, it would give oh.
10 in 10, they gave insulin in 10 this thing of the insulin into the normal saline to run very fast, and they gave a subcut. You get it now. You cut 10 in 10 amount as I'm going to books. Answer them why.
The question is directed.
Okay, so we'll get there. We'll get there, don't worry. We'll talk about anti-diabetics, antihypertensives, We'll go through high dedications and all of that.
Madam, when would that be? So that some people will not miss class.
Oh, class is there.
not miss
Make
class.
sure you come every day.
Say you.
That's
That's the
I
one.
will send it to Nasty.
Madam, wakasama ni huo.
Okasama no.
At the class, I'm a job busy. I said class, so my job busy.
Emisa.
What part ya yefia?
When you be any more questions?
Madam,
What's it,
No,
Jumane?
madam, let's close. No more questions.
Okay. So have a good evening.
I'm imagining you dealing with children.
Yeah, imagining.
You dealing with children, even adults crying who's not in Kuala.
Oh, it's actually easier.
Hey.
It's actually easier. When you're IV now, no.
Look, I collect one. When you said the nine, I can't answer it. How the breast milk can me can you?
My history taking pediatrics, so you have a clue. Say, oh, small things. And your baby, sir. Your man getting no more.
Fancy Mary be a manano.
If you can grab what another prescribe,
Have a good night.
Right, look.
okay.
Oh no. Hey.
10 in 10, right?